Okay. Hello. Welcome. Thank you for joining us this afternoon. We'll give it a few moments so that everybody can get logged in. While you're waiting, please feel free to go ahead and sign into the chat, especially if you have not formally registered for this, or if you're calling in through a cell phone that doesn't show your name and your credential, please do sign into the chat. Hey, Jenny. All right. Well, it is 12 o'clock on the dot. Let's get started. Welcome to our inaugural system-wide Grand Rounds series. So we've shifted from specialty specific to now an overarching educational series so that we can feature different medical disciplines throughout the hospital. So I want to welcome you to that. Thank you for coming to this. My name is Dr. Francesca Varallo-Sims. I'm the Director of Education for Behavioral Health, Wolfson Children's and Baptist Medical Center. So again, just a few notes before we begin. Please sign into the chat, especially if you join by phone. And I'd like to introduce our presentation speaker today, Jay Pygott. Jay is a licensed clinical social worker with a variety of mental health experience working with adolescents and adults on inpatient and outpatient levels. They have been involved in mental health, social justice, advocacy through local and national organizations, such as the Nonprofit Center through the LGBTQIA+ Emerging Leaders Program. Their areas of expertise include trauma, LGBTQIA+, depression, anxiety, bipolar disorder, addiction, substance use, mood disorders, and more. Welcome, Jay. Thank you so much for being with us today.
Good afternoon. Thank you for having me. So, as Dr. Varallo-Sims mentioned, my name is Jay Pygott. I'm a licensed clinical social worker, and I'm a mental health therapist at the Children's Center at the South Bank office. Today we'll be talking about a couple of things. It'll be disparities in healthcare and mental health for the LGBTQIA+ population, and building a framework to provide competent care. So our agenda today, we'll first cover basics about the LGBTQIA+ population. We'll define minority stress, describe why it's important for understanding health and mental health disparities for this population. We'll identify social determinants of health and mental health disparities for this population. And then we'll shift and we'll start identifying solutions for decreasing the disparities and strategies for decreasing barriers to competent care. And finally, I'll provide some resources that are local and national that you all will be able to draw upon to help ensure that you're providing competent care as well. So currently, it's estimated that there are more than 2 million LGBTQIA+ youth that are 13 to 17 in the United States. About 20 million adults identify as LGBTQIA+. And a really interesting statistic is that 21% of Generation Z adults identify as LGBT, which is nearly double the proportion of adult millennials. And I think that that's important because it shows a real shift in our culture of acceptance and the fact that young people and young adults are feeling more comfortable to be themselves and identify in public how they want to. So now we'll talk about some of the basics. So you'll hear me say SOGI, which stands for sexual orientation and gender identity. These are two separate things, and it's important to talk about each of them independently. Gender includes biological sex, which would be considered sex assigned at birth, gender identity, and gender expression. We'll talk about all three of those later on. And then sexual orientation involves behavior, attraction, and identity. And it's important to note that one does not depend on the other. So sexual orientation and gender identity are mutually exclusive and have no bearing necessarily on the other. So when we're thinking about this, it's important to look at everything as being on a spectrum. So sexual orientation, we've often heard of as being on a spectrum, and you may be familiar with something called the Kinsey scale, which was first published in 1948. It's a scale of 0 to 6. 0 is exclusively heterosexual, and 6 is exclusively homosexual. It does have limitations, especially in today's world. One of those limitations is that it excludes non-cisgender people, and it doesn't consider identity or romantic attraction. So think about where you may fit in on any of these spectrums. So the 3 dimensions of sexual orientation that we talked about, we'll get into more detail here. Identity, behavior, and attraction or desire. Identity is described as how you label yourself publicly in terms of your sexual orientation. Behavior would be what you do sexually with other people, and attraction or desire is who you're attracted to. These dimensions apply to everyone, not just the LGBTQIA+ population. What's the significance of this? Often attraction or desire don't necessarily lead to acting on behavior or public identification. And behavior doesn't always lead to public identity. To give an example of this, in a study in New York City, 10% of men who identified as straight have had sex with another man in the prior year. Between 77 and 91% of lesbians had at least one sexual experience with a man total, and 8% within the prior year. This is important to think about when talking with patients. Someone might say that they're heterosexual, but that doesn't mean that either of the other 2 dimensions align exactly. Someone may identify as heterosexual, but still have sex with someone of the same sex or a gender that is not cisgender. So when does a person actually start experiencing and developing attraction or desire? When do people start having sexual experiences, and when do people start having a public identity that involves their sexual orientation? Earlier studies estimated that this was a little bit later in life than more recent studies. One of the important takeaways from this is to note that no matter if the person is gay or lesbian or bisexual, they're having the same experiences at the same ages as their cisgender counterparts. So move on to gender identity. These are some common terms that you'll hear in relation to gender identity. Gender identity is defined as an individual's internal sense of being male, female, or something else. Someone can be transgender, which would be a term for people whose gender identity, expression, or behavior is different from their sex assigned at birth. And someone can be transgender and fall into the category of genderqueer or non-binary, which is a term used by some people who identify as neither entirely male or entirely female. Some people also identify as gender fluid, which is a person who experiences their gender that is more fluid and moves back and forth between masculine and feminine, and sometimes a combination of both. Gender nonconforming or expansive is someone whose gender expression is different from societal expectations. People who are transgender, you may hear them referred to as female to male, or FTM, which is a person who is assigned female at birth but identifies as male. someone who's male to female, or MTF, which is a person who was assigned male at birth, but identifies as female. And then cisgender, which is a person who experiences their own gender as the same as they were assigned at birth. So somebody who is not transgender or under the transgender umbrella. So these are some of the identities that people may experience their gender that are not cis. Non-binary technically is under the transgender umbrella, but there are a lot of different identities within non-binary. So I separated them here to give you an idea of all of the different identities that, not all of them, but some of the different identities that people may identify as within your practice. So now we've finished with the basics, and we'll move on to the minority stress model. Minority stress model states essentially that sexual minorities experience distinct and chronic stressors that are related to their stigmatized gender identity or sexual orientation. The idea is that the way that society treats individuals from stigmatized backgrounds impacts both their physical and mental health. Within the minority stress model, there are two major stressors. The first is distal stressors, and those are external factors, including victimization, rejection, and discrimination. Proximal stressors are internalized homophobia, rejection, sensitivity, and identity concealment. Both of those things can be present, or one can be present, one may not be present. But they combine with resilience factors or each other, and that's how you get some of your mental health outcomes or health outcomes. So within this is a concept called intersectionality, which is something that some of you may be familiar with. Intersectionality is kind of just what it sounds like, which is the intersection of multiple stigmatized identities, or being a part of multiple marginalized identities or populations at the same time. So that might be somebody who is a trans woman who is also African American, which would be being a part of three different marginalized groups: being a woman, being transgender, and being African American. So why does this matter? Studies show that LGBTQIA+ individuals are at greater risk for poor mental health across adolescence and adulthood years. LGBTQ+ youth experience elevated rates of mood disorders and depression. They report higher rates of PTSD, anxiety disorders, alcohol use, and drug abuse than their cisgender counterparts. In LGBTQ+ adults, studies also demonstrate disproportionate rates of mental health symptomology due to stigmatization that occurred during adolescent years. And LGBTQ youth are not inherently prone to suicide risk because of their sexual orientation or gender identity, but rather placed at higher risk because they are mistreated and stigmatized in society. So, talking about some of these social determinants of health. This is a complex, integrated, and overlapping system of social structures and economic systems that are responsible for most health inequities that are experienced. So to give a couple of examples from some of these contexts, we'll talk about economic stability, health and healthcare, social and community context. So within economic stability, rejection of LGBTQIA+ youth by families contributes to high rates of homelessness. Recent studies indicate that over 40% of homeless youth were LGBTQIA+. And as you remember from one of the very first slides, It is not 40% of youth that identify as LGBTQIA+. So this is a disproportionate amount of homeless youth. In the health and healthcare context, healthcare providers lacking training contributes to patients dropping out of care, receiving substandard care, and concealing key information in care settings. Widespread experiences of discrimination in healthcare contribute to delays of preventative care, which results in poor health outcomes. In the social and community context, social isolation of a stigmatized group forces socialization into bars, contributing to higher rates of alcoholism, drug abuse, and smoking. Bullying of youth perceived to be LGBTQ is widespread and common. That contributes to poor health and mental health outcomes for LGBTQIA+ youth and adults. And a lack of legal protections for LGBTQIA+ people contribute to less access to gender-affirming care, as well as primary health care. Recently in the state of Florida, there have been several pieces of legislation that have further reduced access to both primary care as well as gender-affirming care. So how does this really end up affecting the LGBTQIA+ population? Well, almost 25% of LGBT+ people report being in fair or poor health, according to a women's health survey in 2020. Additionally, a disproportionate amount of LGBT+ people live with ongoing health conditions or disabilities. 47% compared to 40% report living with ongoing health conditions that require regular monitoring. And 21% compared to 14% of non-LGBTQ+ people report having a chronic disease or disability that prevents full participation in work, school, or other meaningful activities. So from the same study, larger shares of LGBT+ people report negative experiences with their providers compared to non-LGBT+ adults. So double the amount of LGBT+ people than non-LGBT+ people reported feeling like their healthcare provider didn't believe that they were telling the truth. 13% versus 8% felt like their healthcare provider suggested that they were personally to blame for a health problem that they were experiencing. Almost double said that their healthcare provider assumed something without asking. Almost double reported that their healthcare provider dismissed their concerns. And 36% of LGBT+ people reported at least one of these experiences. Specifically for lesbian and bisexual women, this also impacts their access to gynecological care. So lesbian and bisexual women have significantly lower access to gynecological care and feel less comfortable receiving this care than their heterosexual counterparts. The prevalence of osteoporosis and colon, liver, breast, ovarian, and cervical cancers are higher in lesbian and bisexual women, and a higher proportion of this population is considered overweight or obese. In gay and bisexual men, there are higher rates of transmission of HIV, viral hepatitis, and other sexually transmitted infections. There's a higher rate of anal, prostate, testicular, and colon cancers. And there are higher rates of body image and eating disorders described. So what actually leads to LGBTQIA+ patients feeling this way? About 10% of lesbian, gay, and bisexual, and 21% of trans patients have experienced harsh or abusive language. 8% of LGBT patients and 27% of trans patients have been refused care altogether. 28% of trans patients report being verbally harassed in a medical setting, and approximately 2% report being physically attacked within a doctor's office. So this would tend to lead people to not disclose their identity, feeling unsafe to disclose their identity, or there's assumption of heterosexuality just not being asked. That's one of the most significant barriers, is the provider just not asking about their LGBTQ identity. So to continue with some of the barriers to care, there are two main types of barriers that we can talk about. One is personal level, which would be the attitudes, beliefs, and behaviors of us as providers and individuals within the healthcare system, as well as patients who are receiving care in the healthcare system. This is implicit or unconscious bias. Structural level barriers are created more at the macro level. And these might be state or federal policies. They might be organizational policies. It might be something as simple as the intake form, or only having gendered restrooms. So unconscious or implicit bias is the influence that unconscious thought patterns have on behavior. Clinically, this manifests itself as avoiding topics of conversation that are uncomfortable. You might spend less time interacting with patients that you're not comfortable with, or neglecting to ask certain questions, or other subtle patterns of behavior that affect the patient-provider bond. Now we'll talk specifically a little bit about mental health. So according to the Trevor Project survey of 2022, 82% of people that they surveyed had a desire for mental health care, and 60% wanted mental health care but were unable to receive it. That's a big discrepancy between wanting care and having access to care. So why weren't they able to get care? This survey specifically looks at LGBTQ youth. So these are the top 10 reasons. This might be, this is a demonstration of how the distal and proximal barriers and stressors from the minority stress model can come into play. So some distal stressors here would be the discrimination, rejection, and financial issues. Some of the proximal stressors would be fear, fear of being outed, fear of treatment not working, and fear of not being taken seriously. So the Trevor Project also looks a lot at LGBTQIA plus youth suicide risk. So in the first graph, you'll see 47% of high school students who were gay, lesbian, or bisexual had considered suicide in the last year, versus 14% of their heterosexual peers, and 26% had attempted suicide in the last year versus 5.2% of their heterosexual peers. In the lower graph, this looks at LGBTQ youth specifically, and it looks at transgender or non-binary youth versus cisgender youth. So this is a disparity within a disparity. So trans and non-binary youth are at a much higher risk for considering and attempting suicide than their cisgender LGBTQIA plus peers. So what are some trends in mental health and suicide risk over the last 2 or 3 years? As you can see, things haven't really improved. Everything except for attempted suicide has increased, with a more significant increase in anxiety and depression in 2021, which would be coming off of a lot of the COVID restrictions. So now that we've talked about all the ways in which LGBTQIA plus patients may lack care or may struggle to engage appropriately in care, how do we change that? How can we make it easier for LGBTQIA plus to access care? And what can we do to provide better care when we do see LGBTQIA plus patients? So we'll talk about each of these more in depth, and some of them we may not need to, but asking open-ended questions, understanding the unique health and mental health needs and issues of the LGBTQIA plus population, knowing the terminology that we talked about, understanding about stigma and the minority stress model, really just treating LGBTQIA plus people as people, understand and consider appropriate screenings, taking a sexual history, and understanding and having awareness of your own unconscious bias and microaggressions, having family and partner issues that are unique to the LGBTQIA plus population. And this really a little goes a long way. Just asking about someone's identity can make a huge difference. Taking just a moment to ask and listen to what they have to say and be engaged with them will really help improve your bond with your patients, and it will improve your ability to provide care that they really need. So what do we mean by open-ended questions? So instead of saying, are you gay or straight? Maybe, how do you describe your sexual orientation? Instead of assuming a person is cisgender, asking them, how would they describe their gender identity? Instead of assuming a person is heterosexual or that they only have partners who identify as male or female, asking what the genders are of their sexual partners. Instead of saying something like, what's your real sex? Or, what gender are you? Or what were you before you transitioned? Asking, what's the sex on your original birth certificate? Or what sex were you assigned at birth? A very nuanced thing is the word preferred. Preferred has long been used to ask people about their pronouns and their name. The problem with using the word preferred is that it indicates that it's optional. So if you ask someone what their preferred pronouns are, the message that's being sent is that you don't actually have to call them those pronouns. They would just prefer for you to do that, and that you don't actually have to call them by the name that they've told you that they go by. It's just a preference and it's optional. So we can change that language and say, what is your chosen name? What is your affirmed name? What do you go by? What pronouns do you use? What name do you use? And also having gender neutral language. This is something that I think can be easily overlooked because we do live in a world where most of us have grown up in a gender binary. I see a lot of adolescent, teen, and young adult patients, and I can count on one hand the number of times that any of my young patients have actually gendered a partner or their friends when talking to me. It is always they always refer to their friends and partners using they, them pronouns. And I think that really speaks to the fact that it's not important for me to know And it's important that their friends and partners are referred to as whatever gender they want to be referred to as, or just easily, instead of having to explain anything, just using gender neutral language. And when talking to LGBTQIA plus patients, you will make mistakes. Mistakes are unavoidable. Everyone at some point will misgender a patient or a person in their life. They may accidentally use the wrong name. The important thing here is to just apologize. Apologize and move on. And more often than not, people are pretty understanding as long as you apologize and they know that it wasn't malicious. So here's a chart that just kind of gives you an idea of ways that you can replace some language that is outdated or offensive or hurtful for the LGBTQIA plus population. So what are some changes that we can make on a policy level? So macro level policy, we can increase funding for mental health care in general. We can increase funding for gender affirming care, supporting access to care. So that might be insurance reimbursement for telehealth, insurance coverage and approval for gender affirming care, and another macro policy thing that we can do on a federal level is to get rid of conversion therapy. And if anybody is unfamiliar with conversion therapy, it is the practice of a mental health professional who their main goal is to convert the person from being LGBTQIA plus to being heterosexual and cisgender. There's a lot of research on conversion therapy, and research shows that it is incredibly damaging to the individual who receives it. How do we reduce stigma and fear? How do we do that in a public forum? How do we do that policy-wide? One of those things could be public health campaigns, campaigning for awareness of health issues that the LGBTQIA plus population experiences, and destigmatizing that and showing people that this is a normal part of life, and that LGBTQIA plus people have health issues, and that they're humans, and that they go to the doctor and they do all the same things that their non-LGBTQIA plus counterparts do as well. Reducing stigma and fear may be systemic changes in smaller communities or institutions. That could mean creating roles like patient navigators that help an LGBTQIA plus person navigate the healthcare system and access the different levels of care that they may need. And this could be providing multiple care options because there's not a one size fits all approach to healthcare in general, and also definitely not to the LGBTQIA plus population. So what are some organization or clinical level changes that we can make? Improving cultural competencies of healthcare providers through inclusive education and training, which is what we're doing here today. Hiring a diverse workforce, collecting SOGI data, which goes back to asking the questions and documenting. Having LGBTQIA plus brochures and literature in waiting rooms, having stickers that may say this is a safe space, make sure that you have gender neutral bathrooms and changing rooms, and maybe wearing something that shows your support for the LGBTQIA plus population. So what are the practical applications of this? What does this actually mean for our practice? So building trust by creating an inclusive healthcare environment. We do that by inclusive non-discrimination policies or intake forms, having visual cues in waiting rooms. Baptist provides us with rainbow lapel pins. They're free. You can get one, and I know that it makes a big difference to patients to walk up and see that. I've had many people immediately look at my my badge and the rainbow pin that I have on it, and say, "Oh, okay. Well, I guess you're okay with this, so we can talk about it." Record the person's name and use and pronouns, and advocate for that being system-wide use. Advocate for training for all staff and providers, advocating for safe and respectful workplaces, not just for patients, but also for all of us as providers. How do you build trust? Build trust by acknowledging potential distrust of health systems and professionals. Just asking an LGBTQIA plus identified patient, have you had any poor experiences with healthcare providers in the past? And listen to it. It may help you avoid some of the negative things that they have experienced before, and it can help prevent you from some of the pitfalls of providing care that might not be ideal for the patient. So assuring confidentiality and asking questions. So ask about it in all situations where sexual orientation and gender identity could be important to providing care and support. Make sure that you assure confidentiality. Ask permission before you record their identity into the electronic health record. Use universal language. How would you like to be addressed? Do you have a current partner? And don't ask questions out of curiosity. Make sure that you're contextualizing sensitive questions to establish clinical relevance. That way, you're asking things that will explicitly help provide care to that patient, and not asking about things just because you might want to know or you think it might be interesting. And so the last part is talking about resources. So the following 4 slides have a lot of resources, and I'm sure that the slideshow will be available to all of you, so you can access these resources if needed. So resources that are local in Jacksonville. Many people have heard of Jasmine. It's an organization specifically for youth. They have a focus on HIV testing, sexual health, health and wholeness programs, care coordination, but also they do help young people with housing. They also help young people with accessing substance abuse care if they need residential help. And Jasmine also has a partnership with Baptist in which we provide psychiatric services and also outpatient therapy services. I'm at Jasmine 1 day a week, providing no cost mental health therapy to youth that wouldn't otherwise be able to access it. The UNF LGBTQ Center, PRISM, PFLAG, the Coalition for Equity, Jack's Youth Equality. These are organizations that you can access and you can help direct your patients to. So a couple of other quick resources. One that I love that Jacksonville has is the Rainbow Notary and Nuptials. It can be challenging to find someone to officiate a a same-sex marriage. So knowing that there's access to that that's specifically for LGBTQIA plus patients is fantastic. So how about national resources? Some of these you've probably heard of, like Gleason, the Trevor Project, National Center for Transgender Equality, the Fenway Institute. A lot of people, you may hear people talking about WPATH, the World Professional Association for Transgender Health. They come out with standards of care, which outline for healthcare professionals exactly what the standards of care are for transgender health. They recently came out with a new one a few months ago. And that standard of care can be accessed and downloaded for free from their website. So that will be the end of the information part.
Thank you so much, Jay. Excellent, excellent presentation. So Avery added another resource, Elder Source. Are you familiar with that one, Jay, in the community? Apparently they offer geriatric populations that are LGBTQ plus training too. So that's really interesting, Avery. We'll definitely have to look into that, training for healthcare providers. So a couple, questions to get from you, Jay. Are there particular ways that you think healthcare professionals can reduce some of that personal and structural bias that you talked about, and in turn reducing stigma? Because if the bias is reduced, you could hypothesize that then the stigma could be reduced too. But what do you think about that?
Yeah, I think probably the most important thing to reducing your unconscious bias is to just learn. Attending, something like this where you learn about some of the things that are, disproportionately affecting the LGBTQIA plus population. Just talking to LGBTQIA plus people. I'm always available. You can always email me and ask me questions. If there are things that you don't understand that a patient has brought to you, please feel free to send me an email or reach out to me on Teams. There's no question that I would be upset answering. This is I'm a person who, it doesn't matter, what the question is. I won't be judgmental. I'll be happy to help walk you through it. And, just seeking out information. And, if you ever have questions, you can always talk to your colleagues. You can always, seek out an LGBTQIA plus peer. And they would definitely be, able and willing to give you some more insight. But I think really it's just about learning and, humanizing the LGBTQIA plus population and, understanding that, we all have the same, end goal, and we all have the same health issues, and we all have the same, desires for life.
Yeah, absolutely. That initial education is key. And, exposing yourself to different groups, so to see what you mentioned at the end, which is oftentimes there's more commonalities than there are differences, so excellent. In terms of, and what you do at Jasmine is wonderful, offering that at no cost. Are there other ways you think in general, and even locally in this community, we can improve resources and access to mental health care, and even for like low socioeconomic status groups that are LGBTQ plus?
I think that there need to be policies federally and statewide that increase funding for mental health care and increase funding for mental health for underserved populations. There are some fantastic nonprofits in this city that do a lot of good work. Obviously, Jasmine is one of them. Um, the Dolores Bar Weaver Policy Center also is a fantastic organization. They focus predominantly on girls and young women, but they also serve um, trans girls and trans women. And they also will serve non-binary or, you know, female to male trans youth. There, there are some resources, but there needs to be more funding so that there can be more providers, more people who are able to provide those services. Um, there, Jasmine also has a partnership with MHRC. So I know that they receive um, some, psych medication management through MHRC as well. And it's just about networking, and I think it's about places like Baptist having these partnerships and spreading the word and starting these, and hopefully they can grow.
Yeah. And one area might be, you mentioned resource about the minority stress model and things like that, but maybe even more research to get sources of grant funding sometimes too, right? And so in thinking about resource, I'm going to pull up a slide for everyone for the evaluation, but while I'm doing that, I'd like to know your thoughts on areas for this population that require more research to maybe enhance and improve some of the aims that we have, which is improving access. What do you think about that?
Yeah, the LGBTQIA plus population is still considered a hidden population. And what that means is that it's very difficult to actually have research on the LGBTQIA plus population. And the reason for that is that people don't often express their identities. And if people are lacking safety, then they're less likely to engage in research that would be potentially helpful. I think that there could be important research on more LGBTQIA plus youth homelessness. I think it's important to talk about family acceptance or rejection of LGBTQIA plus people, not just youth, but also adults. Some LGBTQIA plus adults have come out later in life, and they may struggle with their intimate partner. They may have children, so understanding family acceptance, and I think also understanding what some of the deeper unique health issues are. So, we know that there are higher rates of cancer and higher rates of substance use, but really getting into, what that means long term, and how can we provide those services for the people who are experiencing these disproportionate health issues.
Yeah. So, yeah. And so you mentioned that at the very beginning, people have to, they're in that one chart you showed, there was so much fear cited, you know what I mean, as a reason. So it sounds like that's really where a lot of the work needs to begin so that, like you're saying, we can actually get an accurate picture of the true population and what they are experiencing. So I also want to share, if you can see, you have the QR code for all of the attendees. There's a couple notes in the chat. Everyone will receive a follow-up email too with the links. But if there's any other questions for Jay, please go ahead and put them into the chat now. And while we're waiting to see if there are any more, I'm also going to share a link with you all that is where these recordings of all presentations will be housed, is a new YouTube channel playlist created that's affiliated with the hospital's YouTube channel. And I'll link it into the chat now. But in the meantime, Jay, thank you so much, for your time today and everything that the information you've bestowed upon us. And Avery, great comment, extend this info Certainly. Yeah, I'm in agreement with that. yeah, so this is usually one of those that stimulate the discussion, you know, and then we have more work to do in the background. So any other final thoughts? I'm going to link that for you all here. Let's see. There's going to be different playlists that feature all of the various disciplines that will be highlighted throughout this series. So if you click the link that I provided and you go to playlists, you should be able to see the behavioral health has quite a few because we already had a number of excellent talks. But again, thank you so much, Jay, for your time and continuing to do this work. And we'll all continue to collaborate so that we can meet the needs.
Awesome. Thank you so much for having me.
All right. I hope everyone has a wonderful weekend. Thank you for attending.
You as well.
Okay. Bye-bye.